Welcome to another edition of First in Imaging. I'm Dustin Thomas from Brooke Army Medical Center, joined by Dr. Harvey Hecht, Professor of Medicine at Mount Sinai Hospital and Director of Cardiovascular Imaging at Mount Sinai St. Luke's. Dr. Hecht, thanks for joining us.
It's my pleasure.
So talk to us a little bit about, there's a lot of buzz currently about potentially applying calcium scoring to all non-contrasted chest imaging scans. Can you talk a little bit about that and where you stand on that?
Sure, and actually let me start off with a case example, for instance.
Absolutely.
So if you have a 40-year-old man who was referred for a non-contrast CT scan for evaluation of pulmonary symptoms, and he has a lot of coronary calcium, and the radiologist doesn't report it. And then a year later, because the calcium was not reported and was not acted on, he's not started on a statin, and he dies. He has an MI. So I would ask the following questions. Number one, is this potentially avoidable and catastrophic, but within the standard of care, because the American College of Radiology does not dictate that you should report coronary calcium on a non-contrast CT? Or two, is it catastrophic and avoidable, but because the American College of Cardiology and the AHA do not mandate coronary calcium guided treatment, that, well, it's within the standard of care? Or number three, both the ACR and the cardiology societies are really to be held accountable because they have failed to mandate doing coronary calcium on non-contrast CTs, and they have equally failed to say if a patient has a high calcium score, you have to treat them aggressively. And I asked this question at a presentation yesterday. Numbers 1 and 2 got no response, and everybody raised their hand for number 3, which I was very glad to hear. So why are we not doing it? And should we go ahead and do it on a routine basis? And if you're going to do it, how should you do it? So what do you think about it, Dustin?
Yeah, absolutely. I think in a day and age where we're held accountable to everything that's on the image, I don't know why coronary calcium wouldn't be held to the same standard. Just as if you miss a pulmonary nodule on a chest CT, the radiologist or cardiologist reading that scan is going to be held accountable if that patient is diagnosed with a cancer 6 months from now. I think it's a very similar argument to be made for coronary calcium, especially when the availability of the workstation to read the calcium score is readily available.
Absolutely. So you're sort of preaching to the choir, of course, here. And to me, it's really unconscionable that it is not done on a routine basis, because most of the time, especially in the LD age group, the findings of the coronary calcium on the non-contrast CT would have more of an impact on their health than the reason for which the non-contrast CT was ordered. And yet, if you look at radiologists, the percentage of them that routinely report it, it's really trivial, unfortunately. Radiologists who do cardiac CT will report it, but the other radiologists, which comprise the majority who report non-contrast CTs, simply ignore it. So why don't they do it? Well, number one, they're not told that they need to do it. Number two, they don't understand the importance of coronary CT. Number three, they don't have the time to do it. It adds probably 5 minutes to your routine interpretation of a non-contrast CT, and they're already reading an enormous number of scans per day. Number four, they may not have the equipment, because a lot of the small community hospitals may not have calcium scoring packages, and they may not have gating hardware, which is really the ideal way to do it. So you would have to have the radiologist, to do it most appropriately, gate all the scans. So you're going to increase the radiation dose a little bit, but there are ways of getting around that. You can do iterative reconstruction methods to decrease the millisieverts, but as long as we stay within a 1 millisievert range, which we can do for a total chest CT that's gated. Right now we do probably approximately 500,000 coronary calcium gated scans per year, expressly for risk assessment, but there are another 7 million chest CTs done for non-contrast scanning for other indications. And now, with the U.S. Preventive Services Task Force approving lung scanning, you're going to add another 7 million eligible patients for lung scanning. The overlap between those eligible for lung scanning with those eligible for coronary calcium scanning by guidelines is almost 100%, because all of the lung scan eligible patients are smokers over the age of 55. And that puts the patient at least intermediate risk. Some of them will be high risk. So this is an unparalleled opportunity to identify a large percentage of the intermediate and high-risk patients who would otherwise be ignored by imaging evaluation and who would therefore be misclassified by conventional risk scoring. Because we know that in the intermediate risk group, 55 to 2/3 of the patients are misclassified by Framingham and are correctly reclassified by coronary calcium. And even in the high risk group, it's 1/3 of the patients who are misclassified. Plus, the other thing that I would do is I would, because it's in the field of view, throw in aortic aneurysm evaluation. So really what we're talking about is a triple rule out of a different kind with a non-contrast CT. We're talking about lung cancer, lung disease, that's number 1, coronary disease, number 2, and aortic aneurysm, number 3. And all the information is there. It's no extra cost, it's no extra radiation. So really the question is not, should we do it, but how can we not do it? But of course things take a lot longer to get translated from the should or why not into the reality of doing it. And it's not going to be easy. But it also affords an opportunity to educate all the medical community about coronary calcium, because an internist or a practitioner orders a chest CT. Calcium score comes back, he says, I didn't order this. What do I do with it? And am I liable for acting on it? So if this gets translated into reality, then everybody will be forced to acquaint themselves with the importance of coronary CT. And this is a great help both to the CT community and most importantly to the patients.
Well, Dr. Hecht, thank you so much for that very compelling argument. I think you make a lot of strong points, and we hope to see more on that here in the future in some of the upcoming journals and whatnot. Well, thank you for joining us for this. For more interviews with the CT experts, please join us at our website at youtube.com/firstinimaging.